Okay, so it is 7:30 and we have a robust agenda. So we're going to go ahead and get started. Good morning and welcome to the August HIP Council meeting. We're pleased to have everybody here by webinar once again. I think the HIP staff are getting really adept at navigating these meetings in this way. So welcome. I think if we go to the next slide. So just a couple of reminders. You're entering the call on mute, and the meeting is being recorded. The recording will be linked in the follow-up email. If there's an opportunity for you to make a partner check-in later this morning, you're going to want to raise your hand to be called on, and we'll open your line so that you can do that partner check-in. That time will come around 7:40 this morning. And then also at the conclusion of the presentation later this morning, you can enter questions for discussion. So there's a question function. If you enter your questions there, we'll raise those questions later. We go to the next slide. So on our agenda today, we're going to start with the welcome that we've just had and some brief announcements and partner check-ins. Dr. Newell will talk with us about the COVID-19 update. We're going to have a discussion around racism and xenophobia and some time for question and answers, and then a brief closing, and I will try to facilitate to keep us on time and to our agenda. So first up in our announcements is Nicole Lezen and Maritza are going to speak with us about health centers and Health Center Week.
Thank you, Stephanie. Good morning, everyone. This is Maritza Lara with the Health Improvement Partnership. You might know that this week is National Health Center Week. This year, to celebrate our health centers, HIP partnered with the Safety Net Clinic Coalition to proudly feature stories covering our Safety Net Clinic's COVID-19 response. Nicole Lezen, HIP consultant, will share with us a snapshot of these stories today. Don't forget, you can join the virtual celebration. Simply post a congratulatory message on social media and use the hashtags displayed here, HCW20 and value CHCs. Nicole, take it away.
Okay, thanks, Maritza. So as Maritza mentioned, National Health Center Week is a national celebration, and we thought it would be a great opportunity to show how Santa Cruz County Safety Net clinics are taking care of their patients and each other, not just during this COVID-19 crisis that happens to be front and center for all of us, but really all of the time. And also it's a chance to learn more about any adaptations or innovations that people have been able to accelerate during this time that we might want to hold on to for the future. So a huge thank you to everyone who talked with us from all the clinics. We know how busy everyone is and made time to share photos and stories that we'll try to give you some highlights of here, but there's more on the actual website. The national campaign had designated a theme for each day, so we tried to follow their lead. Next slide, please. So on the housing and homelessness front, we wrote a little bit about the effort to secure some empty hotel space for people who weren't able to isolate or quarantine safely at home because of overcrowded conditions, and also about the Homeless Persons Health Project's tent-to-tent work to offer COVID testing, but also masks, hygiene kits, and all the things they do every day, even when COVID isn't a factor, with wound dressings, behavioral health referrals, and just the outstanding care that they continue to provide as well. Next slide, please. For the Agricultural Health Worker Day, we had a lot to offer, and we have a snapshot of some of the local Campesino Appreciation Caravan work that's happening. Lots of great pictures if you get a chance to go there to the site. You may have seen some of these pictures from local and national media coverage of this effort to tell essential workers how essential they really are, how appreciated they are. But it's also been paired not just with these heartfelt thank yous and signs and notes, but also with health education materials about how people can stay safe and harm reduction messages from Salud and others in both Spanish and Mixteco. So there are lots of great photos and an opportunity to donate to that effort on the site. Next slide, please. And even though every day is Patient Appreciation Day for the safety net clinics and other partners in HIP, we wanted to highlight an effort from Salud and Santa Cruz Community Health Centers that have really ramped up their partnerships with Second Harvest Food Bank to do food distribution. This is a set of photos from Santa Cruz Community Health Center's parking lot, where they started out with a farmer's market model, but the volume increased so quickly that they ended up having staff putting food into people's cars. And in the months between March and June, they distributed 10 times the food and non-perishable items, produce and non-perishables, than a comparable quarter last year. So that added up to 109,850 pounds of supplies. Next slide, please. This just lists some of the ways that we sprinkled throughout the National Health Center Week site to donate to supporters, stakeholders, and allies of all of this work. So we've got the crisis response, COVID response fund from the Community Foundation, Salud, UndocuFund, Second Harvest Food Bank, Dientes. All the clinics have donation buttons on the site, as well as these others that have really stepped up to channel funds directly to people affected and to the organizations doing this work. Next slide, please. So the Staff Appreciation Theme Day, that was actually the topic where we got the most response and stories. And not surprisingly, you know, since we were talking to staff themselves, we have a lot of great pictures again on the site. But the kinds of things we heard about were not just the adaptation to wearing a lot more PPE and working differently outdoors or changing workflows with telehealth, but a lot of bright spots about admiration for each other on how quickly people were able to pivot and adapt to this situation. A lot of silver linings about things like reduced no-shows for behavioral health, telehealth appointments, and just being creative about the response. A lot of concern about how sustainable that is, but really a lot of appreciation for each other and the leadership of the clinics. As one of the Salud interviewees said, we're used to not having resources, less than ideal circumstances, and still having to perform, which is what COVID is all about. Next slide, please. This is just a collage of some of the Santa Cruz Community Health Center staff in their masks, lots of variety there. And next slide, please. These are just from Dientes examples of the multiple layers of PPE and also trying to adapt to being outside and do, which many of you have done. And next slide, please. And Children's Health, the last theme day, was one where there were a lot of concerns that I'm sure everyone shares about keeping up with things like well child visits and immunizations. So a lot of creativity about trying to mesh as much of that into telehealth or video observations, and trying to prioritize the immunizations and well child visits for the youngest patients at first, and then expanding that. And Salud also has done some really creative work to try to make it possible for newborns to be with their mothers who had tested positive for COVID-19, which was a lot of coordination with different parts of Salud, as well as the hospital, public health, OBGYNs, just a lot of work to make that happen by using their outdoor respiratory clinic and creating an isolation space within that. So those are just some brief highlights of the many great stories we heard. I'm sure you're hearing examples like this every day, but it was really nice for us to have an excuse to collect these stories and the pictures with National Health Center Week as a prompt. But we wanted to follow up on prior suggestions to have some kind of record of this to look back on in better times. But just a lot of inspiration for us as listeners to these stories, and we hope for all of you hearing them.
Thank you. I have the pleasure of announcing our combined IMPACT Integrated Behavioral Health Action Coalition and SafeRx meeting on Thursday, August 27th. We're really excited to be able to feature some updates about behavioral health integration and SafeRx, as well as Dr. Stephanie Fiore, our forensic pathologist, with an overview of acute drug-related deaths. And then Dr. Ghilarducci, EMS Director, has also agreed to offer the EMS updates from their perspective, and he'll be sharing some Narcan usage within EMS and Leave Behind Narcan, as well as their frequent 911 user initiative. So please join us 9 to 10:30 on Thursday, August 27th. And just contact HIP if you don't have the info and need it. Thanks.
Thank you, Shelley and Nicole and Maritza. And now we have 5 minutes for partner check-in. So if there's anybody that's interested in offering a partner check-in, if you raise your hand, Anais can let you unmute your line so that you can speak. I'm not seeing any hands raised. Let's give it just another second so people can find that function just in case they're trying. Okay. I think people are really interested in hearing Gail's update. So perhaps we'll just transition a little bit early and, oh, let's see, did we get one hand raised? No. All right, so we will transition and Dr. Newell, we will hand it over to you.
Great. Good morning, everybody. I'm going to give you a whirlwind update on COVID-19 in the county of Santa Cruz. So let's dive right into the data. I'm going to start today with the California data because if you've been following the news at all, you know that there has been a significant data glitch in the state data reporting system. They have solved this at the state level. About 300,000 unreported positive cases of COVID-19 since early July. And they have handed over the mess basically to the locals at this point. So these state numbers are good with continuing slowing. So some good news of the number of new cases per day, as well as hospitalizations, although fatalities continue at some record level days still. Fatalities usually follow hospitalizations and diagnoses by a few weeks. So that's a leftover from our previous peak time in California. And let's look at the next slide. This gives a further explanation of the data glitch and the problems we were having. So the blue bars are the number of new cases daily since April, and it's up to date. And the yellow bar portion is the unreported cases. This was discovered about a week ago, and it was found to go back into the first week of July. And we are impacted locally as well. So I'm going to show you local data on the next slide, but with the caveat that we may be missing up to 150 cases of positives that we have not yet sorted through. What the state has done is give us a series of dumps of data that come in the form of reports that we need to manually sort for duplicates and to separate the positives and negatives. So that will take us through at least the end of this week and possibly into next week. So the data that we have are not yet complete, but give us some idea of which direction we're headed. We think that our curve, the blue, the aqua bar graph, is mimicking the state's curve in a typical viral epidemic curve to some point. But we also started our upward climb in our curve weeks later than the state did overall. And so we may still be on our upward trend. It's really too soon to say. You'll notice that we're up to 6 deaths at this point. And I know that we had at least one more yesterday, possibly 2. So continue to watch our numbers. These are from santacruzhealth.org, our data dashboard. Most of our cases, as you can see in the pie chart, continue to be person-to-person spread. That is, we can identify exactly where that case came from another known positive in a close contact, usually in a household or with an intimate partner or other close contact setting. Next slide. So some geographic and demographic breakdown, and I'm going to give you a preview of further breakdown. But if you look at the race ethnicity table, you'll see that ever increasing disproportionate share of COVID-19 in the Latinx population. This is true across the state of California and has played out in communities of color across the United States. The other thing to note is that our 18 to 34-year age group is our fastest growing and biggest age group of COVID-19 infected people. And Watsonville is continuing to be the hotspot for this virus as well. And next slide. So here's a preview of some more granular data that we'll be posting on our website starting next week. The Black population is not listed here because there have fewer than 10 cases and as of yet are not yet disproportionately impacted in our community. Interesting to note here that 95076 has the vast majority of cases. That's central Watsonville. They have 62% of the cases in that zip code. And next slide. Hospitalization curve and prediction is a little more favorable than it was 3 weeks ago or so. At that time, we were thinking we may be on the upside of that confidence interval, the light blue area, but we seem to be holding steady on that dark blue median line. And so we think we're well within our county's capacity throughout the month of August. And next slide, please. Here's a map from the governor's website, which is covid19.ca.gov, showing California statistics. These numbers should be correct with all of the data included. And we're happy to see the case rate, which is the number per 100,000. It's 252.6. We're happy to see that dropping. Last week it was in the 300s and the week before in the upper 300s. The test positivity toward the bottom is also dropping. You'll see that since we last met, we are now in Orange County, one of the counties on the monitoring list, along with over 95% of California's population, with further economic restrictions. And next slide. So here's Santa Cruz, and if you go to this map on the governor's website, it's interactive and you can check all the different counties, but here's Santa Cruz's data. We haven't confirmed this with our local data, but as I said, this should be correct. And happily, we're down close to our trigger, our goal of 100,000 per 100 cases or 100 cases per 100,000 in the last 14 days. So if this holds true, we're looking good for heading on the downward side of that curve. And our test positivity is holding steady well below the desirable 8%. Next slide. So a reminder about where we are with our economic restrictions. We joined the county monitoring list that's monitored by the state on July 28th. And so that means that a number of different economic sectors were modified or closed. So in the open category, we continue to have all critical infrastructure operations, as well as casinos, which are tribally held and so do not fall under state law. Hotels remain open for essential and non-essential travel, as do campgrounds and outdoor recreation. We know more about the virus now and know that it's safer if we're outdoors. And so the areas that have been modified include restaurants, which are open for to-go, for takeout, and for outdoor dining. Wineries and tasting rooms needed to move to outdoor only, as did family entertainment centers such as miniature golf or bowling. If they're outdoors, they may continue. Outdoor zoos and museums may continue, but not indoors. Same for gyms and fitness centers. and certain personal care centers such as hair care, nails, facials, waxing, and massage. All religious and cultural ceremonies, including weddings and funerals, must be outdoors. And political gatherings, protests, and others must be outdoors as well. And schools, as you've all heard, classroom instruction is not allowed at this point, except by waiver. And at this time, the County Office of Education in our county is not accepting waivers due to testing scarcity. The areas that are closed include certain areas of personal care service where the skin is broken. So that's tattoos, piercing, and electrology. Movie theaters, card rooms, office spaces for non-critical infrastructure sectors, and indoor shopping malls. And next slide. State news, higher education guidance was released, and that's important for us, for both UC Santa Cruz and Cabrillo College. So we have guidance, which is legally binding as they reopen. On Sunday, August 9th, our beloved State Health Officer and Director of California Department of Public Health resigned. We have very strong people in her stead for the interim, and we'll be awaiting appointment by the new leadership by Governor Newsom. And we heard on Monday good news from Governor Newsom that he is funding continued efforts for isolation and quarantine. And next slide. For our local response, the state has trained 4 new full-time case investigators to join our staff, and they're being onboarded this week. That's excellent news because it's pretty quick to train contact tracers, but not case investigators. And we're very short on those in our county, so we're happy to have those. As I've mentioned, we're updating our local data following the data glitch in the state. We're working on a new alternate care site, which will be part of the roadway in Watsonville, which has been leased by the county. And the remainder of the roadway in, 90 rooms over 5 stories, will be used for isolation and quarantine for vulnerable populations. It's now open. It is not restricted for those previously unsheltered. It can also be used for those who are in crowded housing situations. Next slide. So we're prioritizing our cases to focus on outbreaks and the most vulnerable population. And that includes those in congregate living settings like the jail, the shelters, our skilled nursing facilities, residential care, and others. OptumServe site continues at Ramsey Park, and the state has extended that contract through the end of September. There's also a new federal site that's at the Westside Pharmacy in Santa Cruz through a program called True North. It's sponsored by the Department of Health and Human Services, and there will be more information coming on that shortly. They've soft launched. We've started a blue check program through the county, which proclaims businesses who apply to be COVID-19 safer, and there's a compliance arm associated with that as well. And we've asked our healthcare partners, our clinicians, to work with us to enact our isolation and quarantine health officer orders along with instructions, and we're working with our healthcare partners to do that. And next slide. This is an example of the orders of the health officer. That is for isolation. There's another one for quarantine, and we'll be sharing those with, we have been sharing those with the clinicians throughout the community to issue on my behalf when they are testing a patient or otherwise suspect a patient to be infected with COVID-19, and the quarantine will be for their close contacts. And we provide them with instructions, which are on the next slide. A very comprehensive booklet put together by our fantastic communicable disease unit. on self-quarantine and self-isolation. And this enables our healthcare partners to support us in our efforts for case investigation. So that wraps it up for me. And I think no live question and answers today. We'll be doing that through email, as I understand.
If you're open, Gail, there were 2 questions that were submitted and we have 5 minutes until the next presentation starts. And so we could answer those, or we could send those on to you and you could respond after the meeting.
I'm happy to do that now.
Okay, so the first question was whether the county has analyzed why the death rate per 100,000 is so low. Are affected patients younger, or so they have lower comorbidities than other counties?
There's several theories about this. We're not alone in this. The fatality rate has dropped significantly in the last few months. It could be that younger people are getting infected who are more resilient and able to tolerate the disease more. But there's also a theory that the CDC believes is playing a big role, and that is that the face coverings and masking that we're all wearing, and we thought it only protected those around us and not us. It may be that those face coverings result in a lower viral inoculum, and that as a result, we're getting less sick, and that fewer hospitalizations and fatalities may follow. So keep wearing your face coverings, everyone.
Okay, and then the second question we received was, if we go under 100 per 100, does that mean we come off the monitoring list? Or do schools open to a hybrid model?
That question is up in the air. The previous health officer, the one who resigned, was not taking any counties off of the watch list, even if they fell back into normal range or lower risk range. But in a conversation with our interim health officer yesterday, she said that definitely for schools, if we fall off, if we are no longer flagged on the monitoring list, we can then consider opening all schools. And she will be considering that for other economic restrictions as well.
Thank you. We have no other questions that were submitted. And so for those of you, if a question occurs to you, perhaps send it to the email listed on the slide below. And thank you so much for being here, Dr. Newell, and providing the update.
Thank you. And thank you all for all you're doing.
Thank you, Dr. Newell. We don't say enough how much we appreciate your leadership and that of the Public Health Department. So keep up the good work. Thank you. So good morning, I'm a professor at UCSF in the Division of Adolescent and Young Adult Medicine, the Department of Pediatrics. I'm going to turn off my webcam. Apologies for that interruption. So I'm very happy to welcome Dr. Maritza Raymond-Fitch. Thank you so much for being with us. I wanted to just introduce her and thank her for joining us today. She comes to us having presented to Dr. Amy McEntee at Salud para la Gente previously this year, and was compelling and so moving to Amy that she recommended that we bring her here to HIP Council today. This topic on racism and xenophobia is certainly timely. It is completely relevant to the work that we do because it has impacts on our patients, our families, and the communities that we serve. And so HIP, this is really building upon the annual forum that we had back in May, where we heard about policy violence from Dr. Tony Eitan of the California Endowment. So we're building upon that theme with more information and really an opportunity for us to self-reflect and to learn more about this topic. And what HIP is looking to tee up is a future conversation amongst this group, amongst the HIP Council participants, wherein we can have a deeper discussion. But we believe that it's important for us all to hear more and to learn more, and really to reflect upon how we can address and our accountability to addressing these issues in healthcare delivery. So with that, I'd like to ask Dr. Raymond-Flesch to introduce herself and to welcome her again and thank her so much for being with us.
Sure thing. Can you guys see me and hear me?
Yes, we can.
Okay, great. Wonderful. So as people were saying, my name is Marisa Raymond-Flesch. I am a physician at UCSF and a researcher here, and sort of my academic background is that I'm trained in internal medicine, pediatrics, and adolescent medicine, and a health services and health policy researcher here at UCSF. And I'm going to be presenting an amalgam of work to you today that crosses all of those domains, and hopefully instill some ideas about how to bring about change during the times that we're living in. Let me just make sure I can adjust my slides. There we go. Are those moving for you? Yeah. I have no financial relationships to disclose to you guys, but I do want to tell you a little bit more about myself because I think it informs the work that I do, the data that I'm going to present to you, and the lens that I come to my career with. I am the granddaughter of Mexican immigrants. My grandmother worked as a maid. My mom was one of 7 children and the only one in her family to go to college. I was lucky to grow up in the beautiful state of New Mexico, where my high school class started with 1,000 students and only 400 of us graduated, where we lost kids every year to gang violence, where kids had to drop out because of teen pregnancy or financial pressures to make ends meet. And in summary, that really was a wonderful environment to become inspired to do work in public health and adolescent medicine. And so now I've traveled this road through a few fancy schools and up an ivory tower, and all of that balance of challenge and privilege is what brings me to this lecture today. So today we're going to start with some data that's probably familiar to many of you. We're going to start talking about the shifting demographics of the United States. We're going to touch on minority health outcomes. And then we're going to shift to defining racism and talking about some data that shares and shows us some of what we know about the experience of racism for people in the United States. And then I'm going to share some data from one of my studies about the impact of racism and immigration policy on youth in Central California. And then we will close thinking a little bit about racism in our field, in medicine itself. And I'm going to tell you about some work that I've done through the Society of Adolescent Health and Medicine, as well as some efforts we've made at creating institutional change here at UCSF. So in terms of demographics, I bet that most people on this call have heard the idea that the United States is poised to become a minority majority nation. The Census Bureau likes to cite that around 2024, we will become a minority majority country. And that is true. But what is also true is that the number of places in the United States that are already minority majority is growing rapidly. Since 1980, the number of counties in the US that is minority majority has doubled. Most large urban centers are already minority majority in the United States. And young people are on the leading edge of this change. This graph shows you on the left the total number of people who are white, Hispanic, or other minorities overall, and then those who are under 18. And you can see that it's really growing rapidly for those who are under 18. We also know that most infants already who were born in the United States are minorities. And as of this year, more than half of children are minorities in the United States. And within schools, most children enrolled in US public schools are already minorities. And so not only are many counties in the United States minority majority, but children are living in a minority majority community amongst themselves. And I focus particularly on Latinx populations and adolescent and young adult Latinx young people. And that's because immigrants are actually a huge population in the United States. 1 in 4 children in the United States is in an immigrant family, and that could either be that they themselves are first-generation immigrants or that they are the children of immigrants. And so this huge population, obviously, anything that impacts their health is going to have a large impact on the public health of the nation. So what do minority health outcomes look like? My guess is many of this data is familiar to people on this call, so I won't belabor it. But just to restate, in the United States, we know that our minority populations have shorter lifespans, higher mortality from many illnesses, including heart disease, cancer, and kidney disease, higher rates of maternal and infant mortality. And we know that these disparities begin early in life, which is why I'm interested in them from the pediatrics angle. Some data from the CDC for Latinx children, we know inequities begin early with about 50% higher infant mortality than white kids. They have about 82% more asthma and obesity, and 34% of them are likely to report attempting suicide during high school. Really profound and dangerous disparities. And unfortunately for African American children in the United States, the disparities are even worse. They're 250% as likely to die as infants, 200% as likely to experience SIDS and asthma, more than 50% more likely to experience obesity, and 61% experience profound episodes of depression that include suicidality. Really dangerous outcomes for youth. And of course, I'm sure one thing that's on everybody's mind is COVID-19, and people on this call are probably aware that there's been a lot of attention to health disparities. We're hearing about them in the lay press, we're hearing about them in medical literature, and we're hearing about them in public health and public policy literature, with a lot of attention to the fact that COVID isn't impacting all populations equally, and that policy interventions will need to take this into account. I'm not going to spend a lot of time on COVID, but I will share the state level data. I looked for this for Santa Cruz and couldn't find it, but at the state level, we know that there are some really big inequities in terms of both who is experiencing COVID and how they're impacted. So here I'll highlight a few pieces on this chart. We can see that our Latinx population and our Pacific Islander population in California are very disproportionately affected. Latinx population makes up about 39% of California, but is experiencing almost 60% of the cases and 47% of the deaths. Pacific Islanders make up only 0.6% of the population, 0.3% of the population, but they're making up 0.6% of the deaths, so really twice their proportion. And African Americans similarly are disproportionately dying from COVID in California, and across the country, the data for African Americans is even worse. So one question that, of course, we have to ask ourselves as physicians, as healthcare organizations, as public health advocates is why? Why is this happening? And one of the things that we have to be really careful about is thinking about how we shape these questions when we start to ask why. It's possible to get into a very dangerous place with questions like this when we start asking questions like, what are they doing? Or what's wrong with them? And that brings me to the central point of this talk, the question of, so do race and ethnicity have health consequences? We read a lot of medical literature, and New York Times frequently summarizes for us a relationship that goes something like this. Race, something happens, poor health outcomes, right? So what's causing this? And I think it's very important to notice and pay attention to the fact that there's a lot of things along this pathway. For those with a public health lens, for those who are talking to patients regularly, I'm sure it makes so much sense to you that income is on this pathway, that education is on this pathway, neighborhoods influence this pathway, access to care does. And my argument to you today is that all of these are forms of structural racism, that it is race that is mediated by racism and gives rise to poor health outcomes. Race is not intrinsically bad. Put another way, from a recent Health Affairs article, race is not a biological category. It's a social construct with deep historical roots and ever metastasizing consequences. And those consequences are racism. So we need to begin this talk by defining racism, and it's a more elusive term than you might realize at first. I was looking into definitions of racism and ran across an article from the Commonwealth Fund in 2018 when they first attempted to look at structural racism across a bunch of different healthcare providers. And the thing that they noticed is the first obstacle we find is that organizations don't have a shared definition of racism. So it's hard to even talk about. So I'm going to share with you a definition of racism that is drawn from Kamala Jones, who was Kamara Jones, who was the head of the American Public Health Association and an excellent health disparities researcher here in the United States. And she's published this in the American Journal of Public Health. And it's a parable, really, that helps to illustrate the different ways that racism functions. She calls it the gardener's tale. These are her lovely graphics from the article, though I jazzed them up a bit. And she says that the story goes that she moved into a new house and she went out into her backyard and saw these planters. And she was really excited about starting a garden in her planters in her backyard. And she noticed that one of the planters was empty and the other one had some soil in it. So she went off to Home Depot and she bought some new soil, filled up the other planter and planted. And she planted her flowers in both planters. And she waited to see what would happen. And so in the planter where she had just put in new soil, she watched to see what would grow. And one side had this new soil where these red flowers grew up big and tall. And the other side had this old soil where it had been sitting there for a while and these beautiful pink flowers did pop up, but they weren't quite as big and tall and pretty as the red flowers that had this new lush miracle grow soil. And Dr. Jones uses this to illustrate what institutionalized racism is. This is frequently called structural racism at this point. And institutional racism honors its a historical insult. Frequently it's discussed right now in public health as issues like legacies of slavery and longstanding discrimination, as discriminatory immigration policies, things like that. An initial historical insult that gives rise to structural barriers. And then, just though these barriers exist, there's inaction in the face of need. We know that this also gives rise to societal norms and biologic determinism. People simply start to believe that the conditions that exist because of the populations, that these pink flowers are short and not as robust because there's something wrong with pink flowers, not because there's something wrong with the soil. And that gives rise to unearned privilege. And so in Dr. Jones's tale, the gardener sees these pink flowers and doesn't really like them. He says, you know, they're not as pretty, they're not growing as well, and he comes along and plucks them off. And she uses this as an example of personally mediated racism. This is the racism that many people think about when they think about racism. It's racial slurs, it's intentional or unintentional at times. It could be acts of commission or omission. But what it functions to do is maintain structural barriers, and it becomes condoned by societal norms. And so in the last section of this tale, Dr. Jones says that a bee comes along into the garden and it comes to visit the red and pink flowers. And in this case, the pink flowers say, I don't want more pink flower pollen. Could you go get me some red flower pollen? They're so tall and strong, and I want to be like the red flowers. Could you get me that pollen? And Dr. Jones uses this to illustrate what internalized racism is. And this is probably the least frequently discussed type of racism. This racism reflects the systems of privilege that individuals live in. It reflects the societal values that come to exist because of structural and interpersonal racism, and it erodes the individual's sense of value. It's what people come to believe about themselves, and that really undermines collective action that might change the system. And Dr. Jones ends her parable with this question: who is the gardener? When Dr. Jones thinks about it, she suggests that the government that has the power to decide, to act, to control resources is the gardener, and that it's dangerous when the gardener is allied with one group and not concerned with equity. But I'm going to pose to you also that anybody who is involved in any sort of policy at any level, which we'll discuss more, has the potential to be a gardener, has the potential to act, to decide, to control resources, and to facilitate change. So as a quick recap, we learned about 3 levels of racism: institutionalized or structural racism that functions through society norms, creates unearned privilege, and really functions through inaction in the face of need, and works through many different mutually reinforcing systems. Healthcare, housing, education, employment, media, criminal justice, all can interact to give rise to this. Personally mediated racism maintains these structural barriers and social norms, and internalized racism erodes the individual's sense of value and collective action that might actually change these outcomes. This racism can function at many different levels, and I want to share a little bit of national data that we have for you about some of these experiences of racism. This data all comes through a large Robert Wood Johnson Foundation survey about experiences with racism in the United States. And I'm just going to walk through some key points. First, through personally mediated racism, we know, for example, that there's differences in experienced race, ethnicity, violence, or threats. For Black Americans, 42% of them have experienced violence as a result of their race, and about 1/3 have experienced threats of violence. And you can see that's profoundly different from whites, where 13% have experienced violence as a result of their race, and 16% have been threatened. For Latinos, it's somewhere in the middle, about 1 in 5 on each metric. Another indice of personally mediated racism is how people feel where they live. So about 1/4 of Black Americans have considered moving because of discrimination that they've experienced where they live. It's 16% for Latinos and 13% for whites. Unsurprisingly, institutionalized racism is rampant in the United States, particularly amongst law enforcement and courts for Black Americans. 60% of Black Americans report that they've been unfairly stopped or treated by the police, and 45% have been unfairly treated by our court systems. Numbers are also quite high for Latinos, who report 27% report being stopped unfairly or treated unfairly by the police, and 20% have been treated unfairly by the courts, profoundly different from the 6 to 7% of whites. And then in our wheelhouse, another form of institutional racism occurs in healthcare settings. Only 5% of whites report feeling discriminated against in healthcare settings, while 1/3 of Blacks do and 1 in 5 Latinos do. This is the policy that we can change. This is an area where we have control. And so the collective impacts of racism are huge. It can limit access, sorry, my light goes off from time to time, my apologies. It can limit access to healthcare, housing, education. It can give rise to systems like mass incarceration, to chronic stress and trauma, which likely mediate poor health outcomes. We have more and more data to show how that stress response mediates many different health outcomes. And health disparities, injuries and violent deaths, and lower life expectancy all grow out of this racism. And so in considering this, as a researcher, I was interested in finding out what are the health impacts of the United States' rapidly changing immigration policy on California's immigrant youth. At the time that I started this, we had had many recent policy changes related to immigration. I will highlight just a few. We had many different executive orders, including executive orders to increase border security, to expand ICE enforcement by 300%, executive orders to restrict foreign travel from predominantly Muslim countries, attempts to withdraw funding from sanctuary cities, attempts to rescind DACA, actual actions to rescind TPS for several countries, Nicaragua, Honduras, and Haiti, and then El Salvador. And I was really curious, what impact is this having on the communities in California? So I've been engaged in a study for several years, since about 2015, doing community engaged work with some wonderful partners at Berkeley, at RTI, and in the Department of Health in Monterey County. And we've been conducting the Salinas Teen Health Study there. So as all of you know, because we are close neighbors, Salinas is a small urban center of a larger agricultural region in California. And we've been following a cohort of about 600 teenagers there as they transition from middle school into high school. Consistent with the demographics in the community, the teens are about 94% Latino, about half female, 12% are first generation, but 71% have a parent who is an immigrant. And we've been conducting research in the community for some time with the help of other community partners. But as these immigration policies came into effect, we started to hear from our partners that they were having a big effect on youth and families. And so we decided to add a new question to our interviews. We added this open-ended question to find out what teens' experiences were. In what ways do you see the current US president and political climate affecting your community or neighborhood? What about for your friends, your family? How about for you individually? And for perspective, on the timeline that I gave you earlier, we collected this data right in the middle of all of these changes to really see what was happening. And I'm going to share with you some of our participants' responses, as well as some outside data that contextualizes the qualitative data that I'm going to be sharing with you. So first, we heard loud and clear that there's a pervasive climate of fear that these young people were experiencing. And that's really backed by the data that we have from the same time period. Around this time, the Southern Poverty Law Center reported a 50% increase in the rise of immigrant-focused hate groups in the United States. And FBI hate crime data supported this with a rise in hate crime in the last quarter of 2016, with about 58% of that crime due to race or ethnicity. We also know that this was pervasive in schools, with about a third of teachers reporting immigration-related bullying in the fall of 2016. In the words of one of our participants, it makes things more fearful in the environment, even if we are citizens. Now everyone is afraid, and it gets in the way of things. We heard that this climate of fear really impacts parenting as well. Data from the Journal of Adolescent Health in 2018 showed that in a survey of 200 Latino parents, 2/3 of whom were living legally in the United States, there was still 65% who worried about family separation. Again, most of this study was done with parents who were legally allowed to be in the US, and 2/3 were worried about family separation. About half warned their children to stay away from authorities, including police officers, if they were in danger. And one of our participants explained, "My mom doesn't want to watch the news anymore because there's a lot of negativity. It changes the way we feel because we're not safe anymore." We heard that that in part resulted in a disruption to mobility and freedom in these populations. Some of that was due to the threats to DACA and TPS that were taking place at the time, jeopardizing people's ability to stay in the country legally. Some of that was due to increased ICE activity in communities and specific targeting of sanctuary cities by ICE. And then there was also several high-profile cases of deportation around this time, including multiple cases of parents being deported while doing normal parental activities, like taking their children to school. One participant in our study explained, "I think people are afraid of being deported. They're kind of terrorized because they feel that if they leave their house to go somewhere, immigration might come to take them away." Family separation was also on the minds of youth in our study, and we know that the effects of family separation for children are profound. Parental deportation has been well documented to be associated with depression and PTSD. But there's also a huge loss of financial stability for families that experience a deportation of a parent. And this is because deportation frequently occurs at the workplace. And so if there is a sole income provider in the family, they're more likely to be deported than the parent who stays home. On average, in one study, 70% of income is lost in a family when a parent is deported. And there's also an impossible choice that some children are left with, the decision to go with their parents, experiencing forced migration, or losing their parents to the country of origin and staying in the United States. One child in our study explained, "My parents are undocumented, so they could be taken back to Mexico. I'll probably have to go there, and my dreams here will end." We also heard about limited educational opportunities as a result of policy changes. 46% of parents in the study that I mentioned earlier reported that they were concerned about their children finishing school. And this has to do with the reduced financial resources I was talking about related to family separation, and also because many parents were scared to go to work because they were worried about being deported in the work environment. And as I mentioned earlier, there's this possibility of forced relocation, which is incredibly disruptive to schooling for children. And finally, with DACA under threat, many youth wouldn't have access to higher education that they had anticipated being able to engage in if DACA is not available. One participant in our study explained, "There are kids that don't have papers in my community. The president is trying to take away DACA, and that's what helps them get an education. And they may not be able to do that anymore." Youth in our study were also well aware that there were health impacts of the policy changes that were happening. These include anxiety and depression with uncertainty about their own documentation status. And in other studies, we heard that parents were also concerned about accessing healthcare. In the study I mentioned about parents, 39% of parents were avoiding medical care or other services for their children for fear of deportation. And all of this was exacerbated at the time by loss of hospitals as sanctuary sites. One example that I cite here is a very famous, very publicized case at the time of a 10-year-old named Rosa, who has cerebral palsy and acute appendicitis in southern Texas. And in order to get to the closest children's hospital to get surgery, she had to cross an internal Border Patrol checkpoint. I'm sure many of you are familiar at this point with the fact that Customs and Border Patrol can place internal Border Patrol checkpoints up to many, many miles within the United States. And she had to cross one going from south to north from inside the United States, and was taken into ICE custody and had an ICE officer with her at the Children's Hospital while she was under arrest and in need of acute medical care. And she was able eventually to get her appendectomy and was eventually returned to family. But this should not be what people have to endure in order to get emergent medical care or any medical care. One of the participants, and of course, reproductive health has become a big issue for immigrant detainees. And there have been many publicized cases, for example, of young women and young women not being able to get abortions while in ICE care, which is a huge problem given the amount of sexual assault that occurs during migration and immigration. One participant in our study had a different reproductive health concern. She explained, "The one that will most likely affect me will be defunding Planned Parenthood, because that would affect birth controls and STIs. That will affect me in the future." I know this data is pretty heavy. I felt somewhat overwhelmed as I was combing through these transcripts and really hearing the raw experiences of youth in Salinas. And one of the participants in the study summarized how I felt well. She said, "I'd like to speak up about all of this and to change the way things are, but I just feel like I don't know where to start from because there's a lot of things to fix." That feeling of I don't know where to start from, I think has been a really common feeling that I've heard from colleagues in medicine and in public health over the last few years. And so when I find myself overwhelmed with this feeling, what I try and come back to and ask myself is, what are the privileges that you have? And what are the institutions where you can use those privileges? For me, I'm a member of the Society of Adolescent Health and Medicine, and I became interested in thinking about how I could work within the Society of Adolescent Health and Medicine to facilitate change related to racism in the United States. And in particular, started thinking about where I live, racism in academic medicine. I'm lucky to be at an institution like UCSF, where many of my colleagues are also interested in these issues. They're also out protesting with me, walking and asking for social justice in many different domains. And within medicine, I started to think about those colleagues, my residents, my fellows, and my fellow physicians, and think about how they're impacted by racism at all of these different levels. And so I'm going to share a little bit of data that's relevant to that question. This again comes from the same National Robert Wood Johnson survey that I mentioned earlier about racism in the United States. And I'm going to share a few pieces that are relevant to physicians and those in professional settings. The first is the percent of people who experience racial or ethnic slurs by education level. I think what's important to highlight here is that in the gray, you see people who have a high school education or less. And in the black is the people who have a college degree. So for both Black and Latino populations, people who have a college education are more likely to experience racial or ethnic slurs. And I think this has a lot to do with becoming more and more the only minority around as one progresses through the pipeline and through their careers. Another important factor is discrimination in employment. You can see that for Black Americans, this is widely experienced, with more than half Black Americans experiencing discrimination related to pay or when applying for jobs, with about a third of Latinos having the same experience, and about 15 to 20% of white people having those experiences. Within medicine, we know that it does matter if providers are minorities. Minority providers are more likely to see minority patients. They're more likely to see non-English speaking patients. There's data, more and more data, suggesting that they may achieve better health outcomes for racially congruent patients. Some of the most interesting of those studies came out of Oakland pretty recently. And we also know that they're paid less than their peers. When we look at the medical pipeline, we can see that this data in gray is from the US Census, and the data in blue is from the AAMC. So while white people make up more than 3/4 of the US population and are sort of well represented as physicians, Black people only about half to even less in terms of active physicians, half in medical school, and about a third of the total population are active physicians. For Latinx, the numbers are even a bigger drop off. While they make up almost 20% of the US population, only about 5% to 6% of those in medical school and who are active physicians. And the Asian population is the only population that is relatively overrepresented in these groups. And then why does this matter? This matters because the trajectory of these physicians differs. I highlighted already that there's differences in things like language congruence, but we also know that minority providers are more likely to be planning to practice in underserved areas. And this is true across the board for Blacks, Latinx, and Asian providers. In terms of salary inequity, we know that Caucasian providers or white providers are paid at the highest rates in medicine, and those African Americans are paid at the lowest rates, and with other racial ethnic groups being spread in between. And we know that there's actually a greater burden on minority providers in several ways. There has been some discussion of what some researchers and academics term the minority tax. And what this includes is extra burdens or work that minority providers find themselves with as a result of their minority status. For some, this means disparities in time dedicated to promoting diversity in medicine, if they find that part of their calling. For others, it's disparities in available mentors, people for them to look up to and to know how to shape their careers, people who may have similar interests or similar life experiences. And then there's also demands on minority physicians and other healthcare providers to be mentors for those who are coming up. All of this is extra work that they carry. Within academic medicine, we know that there are big disparities for minority providers, similar to those for medicine as a whole. Minority faculty are more likely to do health disparities research. They're less likely to receive a promotion at every level. I'll go through some of that data. Less likely to receive NIH funding, and they report lower perceptions of inclusion in institutional efforts to promote diversity and equity. The one thing I will say about this last point that gives me a lot of hope is that the same research group found that experiences of inclusion and equity are improved at institutions with higher proportions of URM faculty. So there are ways that we can intervene. We know that when we hire more minority providers, there's a more inclusive culture. Within academic medicine, we know that minority physicians are less likely to be promoted at every step of the way. So this is a meta-analysis of a few different studies with data like this. And on this slide, you can see that promotion from assistant to associate professor, so the first major promotion, about 30% of whites make that leap, but only 21% and 26% of Black and Latinos. And then the even bigger step from associate to full, about 30% of whites make that jump, but only 18% of Blacks and 23% of Latinos. As I mentioned, NIH funding is less generous at every step for minority physicians and researchers. And I won't go through this slide in great detail, but I will say that this is sort of where the money is. You can see that at each step in this process, from the applications to whether or not the NIH chooses to review them, to whether or not it chooses to fund them, there is a drop-off for minority providers compared to white providers. And overall, this results in a discrepancy of about 50% in terms of funding. So half is likely to get funding. So adding it all up, there's this huge allostatic load on minorities in medicine. It comes from the racism at every level that they experience. It comes from additional intersectionality that they might be experiencing related to gender, immigration, sexual orientation. And it comes from a limited pool of mentors that they can draw on and a limited pool of mentors that that they belong to as young people and trainees are moving up within the pipeline of medicine and pulling on them. So all of this does seem a bit overwhelming as well. And as I mentioned a few slides ago, one of the things that I wanted to do is figure out how I could begin to affect change in any of these domains. And one of the places that I have privilege and power is within the Society of Adolescent Health and Medicine, where I'm a very active member and serve on the diversity committee there. And so our committee decided to write a position paper that was entitled Racism and Its Harmful Effects on Non-Dominant Racial Ethnic Youth and Youth-Serving Providers, a call to action for organizational change. I'm not going to go through every position in this paper, but I'm going to highlight a few pieces. Again, my light, I'm sorry. I'm going to highlight a few pieces for you. So when we were writing this paper, there were ways that it felt like we shouldn't even have to write these things down. We shouldn't have to say them aloud. And yet we could not find any positions at that time from our society, nor from the American Academy of Pediatrics that advocated this at the point where we wrote this paper. So we took we made some assumptions as we wrote this paper based in science. The first is that race has negative impacts on youth and providers. Racism has negative impacts on youth and providers. That racism functions through structural violence. And that healthcare organizations should develop evidence-based policies and procedures to address racism. Our first position that I'm going to share with you today was that organizations should reaffirm their commitment to justice and equity and actively develop, implement, and evaluate policies and processes to ensure that racism is not embedded systemically. These positions are hard. They sound really lofty. And so for each of the ones that I'm going to share, I'm going to show you some examples of how UCSF and the University of California system has been working in similar ways to facilitate change. So my first example of this position in action is from UC. And UC as a whole, as many of you might know, has been very active in the nationwide lawsuits with the Trump administration on the unlawful repeal of DACA. The UC system also takes great pride in working towards representing the state of California. At UCSF, every year we have an event called the Chancellor's Leadership Forum on Diversity and Inclusion, and it's a reckoning. The university puts up its statistics about the number of minority students, staff, and faculty, and weighs them against the demographics of the population of the state of California, and then talks about the efforts that it's made to close the gap and the efforts that it's planning in the future, and solicits feedback from the community. And I really believe that these are the ways to continue moving forward, to understand that we may never hit that ideal, that perfect representation of California, and to understand that we will never continue to get closer and closer to that goal if we're not working hard at it all the time. Within the School of Medicine, there have been also some structural things that they've done. One of my favorites is that UCSF now requires every new faculty member who is hired to write a statement on contributions to diversity. This is akin to the statement that all faculty members have to submit about their contributions to research, their contributions to education, their contributions to clinical service. And now they're required to write about contributions to diversity as well. And the purpose of this is to really highlight the fact that this is integral to our mission, that everybody who comes into this community needs to have given this great thought and think about how they will continue to do it. And then another program that I benefited from at UCSF is a program called the Dean's Diversity Fund, which is essentially startup funding for new faculty and faculty that UCSF is trying to retain to allow them to engage in research or in clinical endeavors. And this funding is targeted towards people who are underrepresented in medicine and frequently benefits projects for underserved communities. Another position that we took at SAM was that organizations should explicitly pledge to provide equitable care in ways that are visible to youth and families and the broader community. A very simple intervention at UCSF was a poster campaign that we put up that was All Are Welcome. We put these up and made them visible across all of our campuses in several different languages. And this is one small intervention. Other things that you can do that are similar are making sure that diversity is represented, diverse racial and ethnic groups are represented in your signs and your advertisements. You can work with community members to make sure that your intake forms are culturally informed. For example, one thing I hear frequently from the undocumented community is fear of filling out forms that ask for social security numbers, and I think they're frequently not needed. So checking with your community about things that might make it difficult for people to interact with the documents that you have them fill out can be helpful and culturally informed. And then also offering collective spaces for dialogue with your community members that you're serving. Another position from our paper was that organizations should develop, implement, and evaluate interventions at all levels addressing chronic minority stress and vicarious trauma affecting non-dominant racial and ethnic providers. Providers are impacted, and providers are one of your best resources for facilitating change for structural racism. One thing that's happened here at UCSF is that one of our researchers, Alicia Fernandez, received a large grant to establish the UCSF Latinx Center for Excellence. And this center has a mission to advance research in underserved communities and also research and training of those who are underrepresented in medicine. UCSF isn't that far away, so if you guys are interested in partnering with us or in learning more about any of the programs that I'm talking about, you should feel free to reach out to me so that we can talk further about it. At the departmental level, within the Department of Pediatrics, UCSF also has a diversity committee that includes both faculty and residents that works on things like our curriculum, our advocacy, and our hiring practices. We have a residency program that is focused on commitment to inclusion and social justice at UCSF. One of the tracks in our pediatric and internal medicine residency programs is similar. And we have a research profile that includes health disparities research, like some that I'm presenting to you today. And so while I know that we've really talked about what a heavy load, all of the forms of racism and the ways that it percolates out into our structures within the United States, within California, can be huge. I also know that working in a community like UCSF can create ways to carry that load more lightly. And I think that that is possible to do at any healthcare organization. The exact mechanisms for change and for support will be different, but this general philosophy of carrying the load together is really possible through individual efforts that can affect change. So overall, there's a lot of work to be done. I really want to help people who are listening to this talk move out of a sense of paralysis and into a sense of action. I see anyone who is on this call is likely to be a policymaker. I think of policy as uppercase P, which is like federal policy, state policy, local laws. But I also think that there is policy at the institution level that we all have the capacity to change. And so for policymakers and researchers, we need to measure the health impacts of all forms of policy that marginalize racial and ethnic minorities. We need to engage communities in the design and implementation of interventions to mitigate structural racism. And we need to make evidence-based policies at all levels to support the health of these communities. For those clinicians in the audience, there's also a lot of capacity for change as both clinicians and for any of you who have learners as medical educators. You can support youth and families directly, of course. You can advocate for elimination of structural racism that you identify within your clinical practices. You can actively mentor those who are underrepresented in medicine and foster the educational advancement of minority providers and their allies. Since the work that I presented to you, there have been many position papers that have come out. Ours is here at the bottom of the screen, but there have also been really great position papers coming out of the American Academy of Pediatrics on the impact of racism on child and adolescent health. Annals has put out a paper, the American Association of Family Physicians has put out a paper, and the New England Journal has a new race and medicine page that summarizes all of their research published in this space that can be really helpful for knowing what the cutting edge science is about race, medicine, and health disparities. So I'm just going to close by acknowledging our youth research participants whose data I shared with you, the Community Advisory Board in Salinas and my co-investigators, and the mentors at UCSF and other institutions who have helped make this possible, as well as my funding from the NIH. And I'll pause there to see if people have questions.
Thank you so much. As you've been speaking, we've been receiving quite a few questions. We have about 7 or 8 minutes for questions, so I'll start reading them and then continue to send your questions in, because perhaps after the meeting we can follow up and get answers if people have additional questions that we weren't able to get to. So the first question we received is whether in your work you are calling mixed children minorities.
In my work, whether we were calling mixed children minorities, so the way that we defined Latino in my study is based on where parents and grandparents were born or how the participant self-identified. We sort of pooled both of those data points.
Okay, thank you. How do you factor the loss of trust from a POC with healthcare that has been passed down for generations? Not sure you would have an answer, but just interested in your thoughts.
Yeah, I think that's an incredibly important question. My guess is that part of the mechanism that we see about the growing body of data about how minority providers can provide more effective care is related to that question. I think that there are very real huge breaches in trust that have happened between minority communities and the medical establishment in the United States. Also, of course, the medical research establishment in the United States. When we think about Tuskegee, when we think about some of the fertility work that was done in Puerto Rico, incredibly unethical science that happened. So there is this huge breach. It makes sense. I think we have to like acknowledge as providers, as researchers, as public health officials, that it makes sense that these communities are scared of us, are wary of us. And I think that that is one of the reasons that in order to do effective work, we have to work directly with them. To both bring them in as providers, to cultivate that pipeline so that there are providers who look like them, who share that experience, and also as allies to listen, to sit with them at the table with us as we think about how to generate our clinic policies, how to conduct our research, to make sure that it really reflects their experiences and their concerns.
Okay. The next question is, Santa Cruz County is experiencing disproportionate rates of COVID related to issues you have raised, as included in institutional or structural racism. So referring back to the data that Dr. Newell shared, what could you suggest in terms of taking steps? Oops, I'm sorry, I lost the question. Bear with me a moment. In terms of taking steps to address those structures or systems during COVID to ensure that resources are available as needed for the Latinx population that's most affected and the 18 to 34 Latinx population who are our essential workforce.
Yeah, I will answer. I will admit that I came on a little bit late, and so I don't know if I saw all of that presentation, but I will share in general my basic understanding of Santa Cruz is that some of the things that are happening in terms of case distribution, for example, are that there's been a lot of cases in Watsonville. And my guess is that that's, you know, from what I know about the Salinas area, that that's probably related to some of the farm worker populations there, some of the dense housing that they're living in, some of the limited ability to engage in things like social distancing or limited financial means to engage in masking and things like that. I think, again, the ways that we frame these questions are so important. And I think that we really need to take that structural lens instead of thinking about it as an issue of individual accountability. I, for example, will share that I'm skeptical about whether fining people will improve masking. I think that what we know is what we know really well as physicians is that punishment isn't a great strategy for behavior change. And that behavior change might come about better, for example, through pathways related to education, to providing the resources that are needed. I think that this is, many people have written about COVID as just bringing to the surface all of these inequities that have been in place for so long. I think that this is a call to action around the really unacceptable housing situations that many of these families live in, and we've known for a long time about them, but this really emphasizes how dangerous they are. And so I think this needs to be part of a much broader conversation. I personally believe as a public health researcher that all of these things are in my lane, right? Housing is in my lane, education is in my lane. All of these things give rise to health outcomes. And so I think that we need to step back and work more with the other structural partners in policy, that so many policies impact health. And we need to be thinking about things related to all of these pieces like housing, like how to distribute masks to people, like how to make sure that we are working with community leaders who can help educate and advocate for mask use, for example, who might help dispel any myths about concerns related to mask use. We need to be asking, are employers providing masks? Are the people who are the bosses for each sort of team of people out there where we're worried about transmission, are the bosses wearing masks? Are they modeling that behavior? Are they getting the message from their bosses that that's necessary? Like, what is the structure and how can we change the institutional culture rather than making it about sort of punitive individual responsibility?
Okay. So the next question we received was from DeAndre, and it is, as an African-American in healthcare, there are so many truths that your data show that I have experienced. How do we close this gap? What do you think is the first step?
Yeah, oh gosh. I think that the first step is naming it, right? That's my goal today, like naming it and making it part of the conversation. I think the first step is getting past photos and sort of promotional material that has diverse actors on it, and getting into the exam rooms with people who are racially and ethnically diverse as providers. I think getting them up into the leadership pathway, I didn't share, but one piece of data that UCSF examines every year at that meeting that I called our reckoning is that pipeline all the way up. And so I think really thinking about how to pull minorities up into leadership positions, how to create opportunities to interface with both the community and with minority providers in large institutions. I've been advocating for a while, for example, at UCSF, that our diversity committee within pediatrics become basically kind of a consult group. For example, there aren't that many of us who are minorities in medicine, in academic medicine. UCSF has many more than most institutions, and still we are a rare breed. And so we get asked to be on like every committee and everything, right? And so I think that if we can shift a little bit to creating spaces like this committee that I'm part of, where I go in part because it is a safe space for me, because I find it enriching to be amongst other providers who have similar experiences, because I love to see the residents coming up in the system. And also it could be used as like a consult group. Instead of asking each of us to serve on every committee, maybe major decisions and major issues could come to that group for our opinion, and not have us be burdened by sort of weekly meetings at other places for everything. I think thinking about things like that, how we can restructure things. Another thing that I would suggest is providing active mentorship if possible. And doing it in group settings if possible, again, to avoid that huge burden on those further up the pipeline. So if you are a large institution that does have other minority providers, thinking about, can you facilitate ways that those providers can connect regularly to support each other, and what can be done in those ways.
Thank you. It is 8:57, and Elisa had one closing item that she wanted to connect on. I want to thank you for all of the content and for spurring this thought and conversation across this forum. I know for HIPC, this is going to be an ongoing dialogue that we have here in Santa Cruz County, and I think people are also really committed to action. So thank you for being part of this conversation. We really appreciate it.
Sure.
There was one other question. If additional questions are remaining for people, go ahead and send them in, and then we can follow up with responses. I'm going to see if Elisa is able to come back so that she can close us out. Are you here?
I am here, Stephanie. Can you hear me?
I can hear you. Good. Thank you.
Thank you, Marisa. Very rich presentation. So appreciative of your time, and do look forward to interacting with you and engaging in your work in the future. So thank you again.
Thank you.
Of course. I wanted to just end the meeting. I have some bittersweet news for all HIPC participants, and please share with your staff that this is Ryan Bruno Maguyao's last HIPC meeting. Those of you who know Ryan know that he has been with HIP for almost 6 years and was a member of the team when I started as executive director back in 2015. And since that time, he's been my right hand in so much of HIP's transformation and achievements. Ryan began at HIP as an executive assistant and leaves us as HIP's operations manager, a key administration role responsible for both finance and HR. Ryan has also been instrumental in HIP's community forum, annual reports, and our continuing medical education events. I'll share with you that Ryan has an exciting path. He will be taking a new position as a fund development director at an educational nonprofit in Mountain View. And we are tremendously appreciative of all that Ryan has contributed to HIP. And I want to say especially his perspective as a UCSC sociology major, a Watsonville native, and a Filipino American. We will miss you, Ryan, and we wish you well in your new exciting endeavor. So with that, I'll go ahead and end HIPC for this morning, and we look forward to seeing you later in September.